Hey, this is Ash from All Things Dentistry.
The place where we're passionate.
About sharing those unwritten hints and tips of dentistry. This is my daughter, Kate.
Hi.
We've got an amazing interview with Dr. Nasseh. So let's jump into it.
I can't show this one yet because it's using actually a system, Ash, that we're going to launch next week at the Greater New York Dental Meeting.
I am so grateful, Dr. Nasseh. Thank you so much for joining us this evening. One of our leaders on YouTube, especially, but also in the real world with endodontics. And I'm very grateful. I know my whole subscriber group is very grateful for your time. So the floor is yours, sir.
Well, thank you so much, Ash, first of all, for having me. And I also enjoy your channel and all the good stuff that you do in the endodontic domain, as well as all of the other stuff that you cover. You know, it's the benefit of being a dentist is the ability to not only just work on this little area that I spend all my days working on, but also the endo restorative continuum and everything that follows, which is all important. Obviously, you know, we're not just doing root canals, we're just preparing a foundation for the patient to have, you know, health and aesthetics and function, which is the ultimate goal. So Ash, you wanted me to kind of talk a little bit to you and your viewers about the ESR system, which is a new reciprocating system that we've kind of helped develop at Real World Endo and is distributed by Brasseler USA. And it is an attempt to address people's reciprocating needs. The system is a series of files that involves a screening file, which is a primary file. And then you have a number of master files, which is size 2004, a 3004, a 4004, and a 5004. There is also a scout file, which is a 1503 that comes in two different flavors. And one of them is martensitic or heat treated, which is used for those incredibly difficult pretzel-like roots that you may have to run into. But the one that I probably prefer is because to me that's too flexible. The one that is not heat treated, and this is the austenitic one. And it's a little bit nicer in terms of the ability to cut, because as you know yourself, Ash, is what you gain by the increased flexibility of the martensitic files is what you lose in terms of their cutting efficiency. So you have to kind of make this bargain, if you will, as to what is your priority. Do you want to have cutting efficiency, in which case you want to have files that are a little bit more towards the austenitic side of the spectrum, or if you want to have more flexibility, in which case you want to have files that are more on the martensitic side of the spectrum.
So I want to take a second just to introduce a course that I have. It's called Root Canal Like an Endodontist. You know, have you ever felt stuck during a root canal? I have. Can't get down a canal? I have. Blocked out ledge, all of these things, but you feel alone. Just starting out in end dentistry, and you kind of want to find out a few more techniques about endodontics. Well, I gotta, you know, I felt the same way. So I've taken all the stuff, all the years of experience, I put it into a course, all my training. We put it into a course, and you can go ahead and check us out at allthingsendo.ca. You know, what I really love about this course is our Facebook group, that once you purchase the course, you can get access into it. Sorry, it's one of those things. But there we share in a very a warm place. I just copied that here, warm, but it's also a safe place to share questions and concerns about any of the cases that you have, and we walk you through it as a group. Anyways, go ahead and check us out at allthingsendo.ca. And I'm sure you won't be disappointed. We'll talk to you soon.
So the real question first starts by the kind of tooth that you're dealing with. If it's a straightforward normal tooth, then clearly, you know, files that are a little bit more on the austenitic side will suffice. But if you have something that's super challenging in terms of in terms of the curvature and so on, then you want to have heat treated files. So you have that option when it comes to this guy here, which is the Scout. But what we've decided to do is with these main files is to have files that are heat treated, but somewhere in the middle. So you get a lot of flexibility so that you can take this size 30 file and kind of bend it completely, you know, like this. And you have a lot of flexibility there. But at the same time, it has a nice cutting efficiency because of the blade design. So these files are used in a very kind of intuitive way. I wanted to kind of come up with an algorithm for their use so that they would be they would have a robust use for basic cases, which you can, you know, as a restorative dentist, you could use then for your anteriors and premolar teeth and so on. and even something where you could use for your molar and more complicated cases. So the goal here was to develop a protocol and an algorithm for the use of these files in a manner that allows you to use the least number of files possible to do a root canal. And to me, Ash, as you may know, many companies kind of promote their file reciprocating file system as single file systems or single file techniques. To me, that is just pure marketing. It is not really responsible to use a single file system because you just don't know how wide the canal is before you would use your rotary file. So, or your master file. You can't make that decision based on a radiograph. So the minimum number of files, in my opinion, that one has to use prior to completing the case is two. One file has to go in there, screen the canal, engage the canal, and then you would use a second file then to finish it. So a gauging file and a finishing file. So that means you really need to have two files at the end of the day. And that's really the purpose here is we have one file, which is this 2506 file, which is our equivalent to the primary, or it's a screening file. And what this file does, it will tell you based on how far it goes into the canal, whether you're dealing with a small canal or a large canal. And if it's a large canal, is one in which this file goes all the way down to the end of the root. And then you have a choice of two different finishing files, either a 40 or a 50. And that depends on how easily this goes down. If it goes down super easy, usually a 50 would be the finishing file that you want to use. If it has a little bit of engagement on the way down, the 40 might suffice. Now, if this file does not go down, then it means you have a small canal. And at that point, then you have these two options for finishing files, either a size 30 or a size 20. So we wanted to have this 20, 30, 40, and 50 sequentially as your four master file finishing files, if you will, so that it could be kind of intuitive. And these are matched with corresponding size endo sequence and BC coded cones, and these cones are going to be basically matched with this. And then you use your bioceramic cement to kind of close the circle and be able to fill in the gaps. But what's important here is that these 20, 30, 40, and 50 are O4 taper, constant taper preparations. So what's nice about a constant taper preparation, Ash, is that at the end of the day, they are far easier to obturate than a variable tapered instrumentation that you end up having, because you end up with a variable taper shape, and it's not quite as easy to fill, which is part of the reason why the variable taper shapes require or use thermoplastic gutta percha or obturators. And those are nice techniques, except that the obturator technique is way too expensive comparatively speaking. And if you are going to do vertical condensation, that is also a little bit more technique sensitive. So what we wanted to do is we wanted to develop a system that allows you to take advantage of the benefits of bioceramic obturation using hydraulic condensation. So if we could end up with a shape that is fairly minimally invasive, such as an O4 taper preparation that you get with these four finishing files, it's going to be obturated easily with one cone, or if you have a very wide canal, additionally, maybe a second cone or something like that with bioceramic, and that would be your hydraulic condensation case. Now, you could also just use a 25 to finish the case if you have a tooth that is fairly tapered, because that is also a constant taper 2506, which many people actually like as a finishing master file. And that could be matched with the BC cone of its corresponding size. So you literally have these 5 files that you could finish with, and it kind of covers a large spectrum. Now, one of the differences between this system and some of the other single file reciprocating systems is that those are designed to be single use, and the little rubber piece on the handle may expand after autoclaving. So they're forced to be single use. But these are autoclavable, so they could be reused for those people who may do a very simple case and may think that the file really didn't get engaged too much, and they don't want to have it thrown out. I personally use these cases myself, although I must emphasize the manufacturer recommends their use a single use. I think that's basically what all manufacturers do nowadays. But I personally use them in 3 canals. So if I'm doing a molar, I would use the corresponding size and then use that in 2. Now, remember again, you're not going to use all of them. This is just the algorithm that you would be using for the case. In most of the cases, you're using 2 files per canal. So, I'm just having all of them kind of displayed here so you can see. So that's essentially it. You use the 25, you triage the case to see how far it goes. If it goes all the way to the end, you either fill with a 40 or a 50, depending on the size. And then if it is, and one of the nice things, Ash, sometimes people say, well, what should I use, 50 or the 40? I don't know which one. And if you're telling me that it's 2 files, then if I use the 40, now what am I going to do? That I'm going to have to throw it out. So that's part of the reason why it's autoclavable. So what I would do is I would just take the 40 and by hand, without even putting it in the handpiece, I would push it down to see how far it goes. Does it go to the full length or not? If it goes to the full length, then I know that's not large enough. I would put that away, and then I would use the 50, and most of the time the 50 would finish up 2 or 3 millimeters short. So then I just drive it down the last 2 to 3 millimeters, and that's going to grab that last apical donut of dentin to completely clean and clear out that dentinal area. So, but what's nice about the fact that these are autoclavable is that 40 is not going to be ruined. It's just I'm using it to gauge, and then I just toss it to get sterilized, and it'll be used because it's going to be still brand new. You know what I mean? So that's one of the advantages. So if the 25 doesn't go to the end, then I would, if the 25 doesn't go to the end, I would probably first have to get the canal to a size 15 hand file. Now I could do that with getting into a 10 and a 15 hand file, or I could just go straight to the Scout and get that to a 1503, which then is going to be enough of a path for me to either drive the 30 or the 20. Now the 20 to me is a little bit too thin most of the time because it's an 04 taper. So this is a file I would be using on an MB2 or a very, very thin and calcified canal, including like an MB canal or something like that. But I think the bread and butter of the system ends up being in molars, mostly a 3004. That'll give you a nice respectable shape that is good to fill. And I also may use the 2506 in some of the cases that have a greater taper as a finishing file. So that's pretty much the basics of the concept behind the system.
So you brought up a couple good points just about obturators, and that's all I've actually shown on my entire channel was single cone since the day I saw your video initially years ago. One of the things and that's what I teach, and one of the most, and I preach it because I find that even though there are size verifiers with the thermofill, the problem is you can't take a cone fit film with your cone right at length with the sealer on it. I mean, if you're comfortable with the sealer, great. If you're not, it doesn't matter. But you can get that, especially for general practitioners where there's, endo is so complicated. And, there's the initial phase, there's diagnosis, then there's instrumentation, then there's access, like squeezing your butt cheeks, access, then trying to find canals, instrumenting, obturation, like all of these things. And one of the most frustrating things for all of us, I think, is taking that final radiograph. But it's your final radiograph and you're short or you're long. And that's what I love so much about what you brought together, especially from a teaching and a general practitioner standpoint, is that you can take that cone fit and be like, oh, within reason, right? You have an idea in a 2D image. You're like, oh, I'm long or I'm on the money. And that is it's frustrating to me from a practitioner where it's like, all it's pushed is single file. I don't even want to get into it, but single file, got a core thermofill or whatever it is, an obturator. Whereas you don't have the luxury of just being able to like fix your mistakes before it becomes a permanent, radiographic image with your signature on it. So again,
what you just said there is key, Ash, is the fact that everything we do in dentistry has to be recoverable. That's essentially an important part of everything we do because we're working on patients and we're also human. So we are going to make mistakes. So we should be able to manage these mistakes. So being able to take a cone fit shot or even a cone fit with a sealer in the canal so you can really know where you're ending up is very important, that which is something you can't do with these carrier techniques. Furthermore, carrier techniques is the thing that is nobody really pays attention to, is that each carrier is, at least in the US, I don't know how much it is in Canada, but in the US, it's $10 to $12 per carrier. And that's even without the sealer. Just
Wow.
the carrier alone is $10 to $12. So if you're doing a 4-canal molar, you're putting in $40 just for carrier's cost for obturation. And then your sealer goes on top of that. Whereas the BC cones and gutta percha cones that we use are 50 cents a gutta percha cone. I mean, that's just, so just quickly again, to go over the whole thing as a concept. Again, this is the essence of the algorithm, is that you just do a little bit of hand filing with a size 10 hand file at the beginning, and you use that primary file, which is essentially a screening file, 2506. If it goes to the end quickly, you finish with either a 40 or a 50. If it doesn't go to the end, then you have to get it to a 15 first, or a 1503 scout before you finish with either a 20 or a 30. Most of the cases, I think, going to end up finishing with a 30. Because remember, this is a 3004. The 3004 is actually easier to get down than a 2506, because while the tip is larger, the taper is much greater in a 2506. But that's the option. So essentially, on a basic case, 10 goes to the end, 25 goes to the end, then you finish with either a 40 or a 50. In a more difficult case, you'll have the 10, and then the 25 doesn't go to the end. So what you would do is you would get it to a 15 first, and then finish with either a 30, or if the 30 is short, you'd be finishing with a 20. Just to quickly showing you a case here of an anterior tooth that require on a patient that had a trauma recently with a subluxation, and then the tooth ended up going necrotic, and she was having discomfort in the tooth. And you can see in the CT that we took that you can see the halo radiolucency right at the apex of tooth number 8. There was a little bit of subluxation as well, but the tooth was then kind of repositioned a little bit. And as we know, in adult teeth, subluxations don't do so well. So we always isolate, and I'm using the endosequence flowable dam for secondary isolation, which is kind of helpful. And then curing it, and then just getting an access directly through this tooth. And so you can see, we want to have a straight line access. Ash, I'm with you as well, that the idea of these contracted access openings, to me, are literally, tariffs, or if you will, protectionist moves to prevent people from being able to just do endo and democratizing endo. To me, there's absolutely no reason to have tiny access preparations, other than for Instagram, you can show that you could do something that other people cannot do. So this is just getting the working length on this tooth. So we get the working length on it. I'm using a 15.
I like that.
Since it's
what is that file? Is that a new?
it's called an ACU file that we had at Braster. Although recently it's just kind of been on a massive kind of back order, and we're trying to figure out what to do. So I'm not sure if it's currently out for ordering, but it's just a nice little convenient file for that. So you can see here, I put the 2506, and the 25 went down straight. And these files, reciprocating files, as you know, work on a counterclockwise direction. So you could use them on these EndoSync Plus handpiece, or if you already have a reciprocating handpiece on which you could use your Reciproc Wave 1, Wave 1 Gold, they would work on those as well. So there's no need to buy a new handpiece. What's nice about this handpiece is that you get connected to the apex locator. So as you saw, what I did, the 40 was, when I used it by hand, it went all the way down to the full working length. The 50 is 2-3 millimeters short. So now I'm just driving it down, and that it reaches the apex. And then now I'm going to use some irrigation, and then do some negative pressure irrigation there. And I'm using Triton, which is the special kind of a disinfectant and chelating agent combination, and then fitting the 50 to the fork and walk. And this is what we were talking about, Ash. The fact that we can have a look at, is this the length that I want to fill it to or not? And then we can dry it nicely. And that's a nice little trick, by the way, I share with people. By putting one paper point in there and blowing air on it, it wicks up the fluids. And then I inject a little bit of sealer in the canal, and then I use a clean file in the opposite direction. So if it's a cutting in a clockwise direction, I would put it in a counterclockwise direction. If the file cuts in a counterclockwise direction, I will put it in a clockwise direction. And then I'm using the heat source to melt the gutta percha at the orifice and quickly come back and just plug it, right, and close off the seams of gutta percha right at the orifice. And then the ultrasonic and water to remove the excess. And then here, just quickly etching and putting a layer of the BC liner, which is what I'm currently using instead of cotton and cavid. And my restorative dentists would then just drill into it a couple of millimeters, use the rest of it as base, and put a pure composite in the access to close it up. And that's pretty much it. And as we go from the simple type of a case into the completion, and that's just the way it looks. We go from this to this. As you saw, we used just the scouting file, the screening file, which was the primary, followed by the other files.
What I really value about what you just showed us, and this is from a deep personal level, is I've watched new clinicians come through, like repeat, and what they're taught in school on most of their cases is that, well, you and I went to school with, I hate to say this, but hand filing, right? And you had to hand file to a certain size. So it is what it is. Like, you kind of like, whether you're doing an apical stop, usually it was like when I was taught. So you had to use large hand files, and you knew what it felt like to actually grab the package and not just know what a 10 and 8 and a 6 are. And what I love, what I just saw is opening up to a 50 on essential incisors, because what I'm learning now is that most of the brand new clinicians coming out, and that's another reason why I'm so grateful for what you're producing, is, it's not a standard size fits all, because what I watch is the marketing of a single file. It's open, the patient, the problem is typically solved because the pulpal tissue is removed, the irreversible inflammation is, that everything's kind of solved. But what I'm finding is that it's not big enough to remove that apical portion. They're filling it, and then we're getting lesions, 3 to 5. I'm sure, better than I know, 3 to 5 years later, and then we've had a few blow up. And really it comes down to not opening up, not preparing it, the apical portion enough, right? So I value not just the file system, but also just showing that case, because it's not shown enough, I don't think.
Yeah, unfortunately, people, I think a lot of endodontists that go out there and give talks, they're kind of used to cases that they're dealing with, which is these tiny, thin canals in the molars. And so they're like, well, I only prepare those to a size 20 or a 25, whatever. And they don't understand that people out there are dealing with different types of cases. And what's most important is to have a system that allows you to gauge that specific root that you're dealing with. So you can literally be able to scrub and scrape that apical 2 to 3 millimeter of the root end with the tip of your file, which is the most effective way to be able to clean and remove the biofilm. You and I had a conversation before going on, if you remember, about doing single visit endo versus multiple visit endo. And this is the key thing. If you want to do single visit endo, because of the fact that you have to rely on removing the biofilm more efficiently, you have to understand that you have to be able to touch those walls at the apical 3 millimeter. So a larger apical diameter would be helpful in terms of cleaning that apical segment much more effectively. Because if you want to be minimally invasive, if you want to do one of these games that people are playing on Instagram and just finish your cases with a size 1704, then it means the file is not touching anything on the walls. Your file is essentially, because canals, we know histologically what canals are, right? So if your file is not going to scrape the walls and clean it out, then you're going to rely on the chemistry of the chemicals that you use to do that. So it's a combination of your irrigation materials and then probably your intraoperative dressing materials, such as calcium hydroxide. So if you decided you want to be minimally invasive and prepare a thin shape, then you really know from the understanding of histology and dental and the root anatomy and microbiology that you're not touching those walls with these small sizes, and then you're leaving bacteria behind. Therefore, what is the solution? Of course, like we were talking about it, you can enter company X or Y, and they want to sell you $100,000 device that can help you with that. But the answer is just to kind of make sure you have an anatomically prepared size at the apex, instead of having to buy a massively expensive device. So just instead of finishing at a size 15 or 20 at the end of the road, go to a size 30 or 4, or gauge it. And if it's a central incisor like this one, you may have to be at a size 50. That's the reason I was so adamant in making sure that we develop and write this protocol, this algorithm for coming to a conclusion as to what your master apical file should be on a given tooth, by using and utilizing a file that will first gauge the canal. So this way, you would have a better chance of knowing what your master apical file should be. Because in some cases, it should be a 50.
Yeah.
Otherwise, you're not going to touch the walls. And in some of them, it would be a 20 or a 30. But that's usually the kinds of cases that restorative dentists want to handle. It's more on the larger size, on the larger side of the spectrum, rather than what endodontists see that are like these tough calcified cases that they're going to end up having a smaller preparation for. So it's really important to know what your practice composition is, what kind of cases you're dealing with, and then how you're going to get the best outcomes from those. One of the things that I see in people that use the obturators is because the obturator will because it's just thermoplastic and it's highly radiopaque, it'll just push on the walls and it looks like it's a good preparation, right? But if you really haven't touched those walls, I jokingly refer to some of the obturators as biofilm compactors, because you have your walls are dirty, and now you put something super radiopaque that is just kind of pressing against the biofilm. On the x-ray, it looks like, oh, I have a nicely filled root, but all you have is basically radiopaque material in a tooth that is dirty. And that's why you see these cases that looks good on the x-ray, but has a large lesion. It's because the fundamental biological aspect of what we try to do, which is to eradicate the biofilm, has not been done. It's just we've filled the tooth with a bunch of radiopaque material. And you know what, Ashley, one of the things that I'm kind of complaining about now is I see manufacturers have caught on to this game that we play, which is just about the radiograph and radio opacity. And they keep pumping more and more zirconia into their cements. They're literally just trying to fill the canal with a radio opacifier compared to something that is actually having some biological properties. So it's really not right. And that's something I teach at the school to our residents. And I say, we really have to get off this nonsensical obsession with the radiographic look of cases and start to move back into understanding the biology of what we're trying to do, which is to eradicate those radiolucent stuff inside the tooth, which is bacteria, biofilm, antigenic substances, and things that cause inflammatory defects in the bone and the periapical area of the tooth. And when we don't do that, then we end up having manufacturers that start playing with our unreasonable, likes of having just dense looking x-rays by giving us more zirconia, which does literally nothing.
Okay, so our total video is an hour. So what we're gonna do is we're gonna come back next week and we're gonna upload round 2, and that continues the rest of our discussion. So thanks for joining us, and don't forget to subscribe, like, and hit the notification bell. We'll talk to you soon. Cheers.